Good morning. So happy to see all of you all here. We're going to go ahead and get started. I am very excited to introduce this session, Optimizing Tailored Prevention Programs and Intervention Services Through Data Science and Technology, with our amazing lineup of speakers. I'm so glad that they all agreed to attend. I think we're going to learn so much from them, hopefully get inspired about the possibilities that are out there for prevention science. So for a long time, prevention science has used tailoring and adaptation to maximize the impact of programs and services. But now there are these advances in data science and technology that represent a new opportunity to take prevention to the next level. Mobile, online, and other technologies provide opportunities to design, implement, disseminate, and evaluate tailored programs and services that tell us a lot about what works for whom, under what conditions, and for which outcomes. So again, just join me in welcoming our amazing speakers. Woohoo! I'm very excited. Of course, with these new opportunities come new pitfalls. So our Friday plenary session will focus on ethical issues and processes around the use of data science and technology. Do you happen to have that screen with the QR code for the ethics plenary questions? That's a good one too. So hopefully we'll get that slide up. Please go ahead and get that QR code, and we will be talking about those questions on Friday. We briefly discussed some of those issues in our planning sessions, and it was already very interesting, so I'm excited to hear what everybody has to say. Also, there is a mid-career survey that flashed previously. We're really interested in particularly increasing retention for mid-career prevention scientists as members and participants in the conference, and we know that there are unique issues. ECPN addresses the unique issues related to early career, and we're hoping to start addressing unique issues related to mid-career too. So if you don't mind putting up that mid-career slide, if you identify as being in mid-career, please go ahead and get that QR code and fill out that really brief survey. And I'm going to go ahead and introduce last thing. Also, stay around for our roundtable. We won't have much time for questions right now in this session, but we will have a good bunch of time for questions in our next session, so please stick around. We're excited for that. Our first speaker is Dr. Deborah Tate. She's a professor in the Department of Nutrition at the UNC Gillings School of Public Health and the interim director of the Nutrition Research Institute. She's a behavior scientist, and her research focuses on two main areas: strategies for improving both short and long-term body weight regulation to reduce disease risks, and the development and translation of programs as alternatives to clinic-based care using digital and wearable technologies. She's been continuously funded in obesity, diabetes prevention, and digital health intervention research by NIH since 2000, and she's known internationally for her work in web and mobile interventions. So let's go ahead and welcome Dr. Tate.
Thank you so much. I'm very excited to be here. This is my first SPR, and I can't believe I haven't been coming to this all along. I'm just really excited to be here. So thank you so much for inviting me. So with the idea of how we are thinking about optimizing messaging for prevention and using tailoring in our next generation, I'm going to first set the stage a little bit about what we know about tailoring and some of the things that may drive us to the research questions about what we want to optimize on and how we want to optimize tailored interventions. So I'm going to give a little background and rationale for tailoring with technology, talk about what and how much we should tailor, and some of this is very open-ended. We don't really know exactly how much is enough or how much is too much. And then I'm going to talk about some of the work that we're doing with optimization designs. I'm not going to go into too much detail because Kate's really going to lay the groundwork and teach us a lot more about that, but I'm going to tell you a couple of studies that we're doing with optimization for mobile interventions. Okay, so my whole career has been driven by one of my early mentors at Brown, Dr. David Abrams, who pioneered this idea in 1996 that reach times efficacy is impact. So as a clinical psychologist, I thought a lot about efficacy and really maximizing efficacy. And then moving into public health, I thought a lot about reach. And so the work that I've done with mobile interventions is to try to marry these so that we can have greater efficacy, but still achieve that reach to have population impact. So I think tailoring is one of the things that drives the efficacy of mobile interventions, and how we tailor is really very exciting for the next generation of scientists. So this is a review that talked about technology-based interventions in my field and what makes them effective, but it really does apply, I think, across a variety of fields. And what they found here is that when interventions had at least 4 of these components, one of which was individualized tailoring, they were much more effective. So I've been working on this for a long time. I published the first automated tailored intervention in 2006, and so comparing once a week human tailored, or an email that was delivered by a human, to a completely automated tailored intervention was this first study, and then comparing that to a website that had similar materials but no tailored messaging or feedback. And the tailoring here was pretty rudimentary. So we were tailoring on a variety of variables, but we were not considering the variables in relation to each other. So we were looking at individual levels on those variables and giving messaging, but it wasn't really relational. And so I think we're moving much further beyond this. But the good news, and this is what's kind of led me down this path for all these years, is that at least at 3 months, the human and the completely automated intervention were equal. And then by 6 months, this is probably a power issue, but in my field, this level of weight loss would be clinically meaningful. And so the completely automated intervention had a 5% weight loss, which would reduce risk for diabetes, would improve blood pressure, would do lots of good things. So this has really driven me forward. I've done a bunch of effectiveness trials. I'm just going to show you one, but this is an automated intervention delivered in WIC compared to WIC usual care for postpartum moms, and the automated intervention over 12 months, which again is with tailored messaging that's delivered once a week, with some other intervention messages that are delivered via text, is more effective than usual care. So let's just make sure we're all on the same page. This is one of the original definitions put forward by our former dean at the Gillings School, Dr. Barbara Reimer and Matt Kruder, that talks about the definition of tailoring. So when we talk about tailoring, we're talking about a combination of information and behavior change strategies that are intended to reach one specific person. So contrast that with targeting, which is more related to group-based. So if you are a member of a certain group, so if I'm a parent, then that's a group-based tailoring versus tailoring to my individual specific characteristics, like my scale responses, my progress on various variables, my levels of self-efficacy or responses on a scale, my responses to EMA assessments or whatnot. So this has been put forward as sort of the continuum of having things that are quite generic in messaging to things that are very interpersonal communications between people. And tailoring falls along this continuum more toward interpersonal communication. And the important thing here is that, most interventions include all of these. So some of the information or education is quite generic. It's just based on, the population, let's say, of general adults, or it could be related to people at risk for type 2 diabetes. That would be more targeted, so segmented towards one type of audience, usually based on race or gender or other defining characteristics, membership of an at-risk group for chronic disease, versus tailoring, which is really specific to the individual. And so in many mobile interventions, there are a combination of messages and education that falls all along this continuum. So There are lots of elements that we pay attention to, and when we're thinking about what makes tailored interventions more or less effective, and so one of the things is directionality. So when we're looking at interventions, is this a push message that goes unidirectionally to the participant based on data that we've received? Or is it something where we're pushing a message out, receiving message back, and tailoring based on the responses? So it's more two-directional. How often are these messages being sent? We know that there's perhaps a sweet spot. I'm not sure if we know exactly what that is in terms of how many messages are the right number, how often. And then the timing. We're going to talk a little bit about learning about the timing. So participant chosen timing, random timing. So figuring out that there's a time block, you want to send a message in the morning, you don't want it to be expected, so you're not sending it every morning at 9, but you're choosing a random time within a time block, let's say between 9 and 11, and you're sending out messages. That's a random during a time block. Or fixed intervals, where you've asked the participant, perhaps based on participant choice, what time they would like to receive messages. So there's a lot of elements of timing. I'm going to tell you a little bit about, at the end, about how we're trying to use passive data collection to determine the right time to deliver a message. So does a person open a message at this time? Are they available? Are they at work? Other kinds of variables that might help us decide when to deliver a message or not. Oops, sorry. Use of behavior change theory, how are we using behavior change techniques or other things like that in the content of our messages? Are we, how tailored, what are the decision rules? So this is based on the algorithms, and I was mentioning you can have decision rules that include one variable. So I'm going to look at my physical activity alone and how active I was today, and I can tailor based on my activity, or I can tailor based on my activity today compared to my activity yesterday, compared to my pattern of activity over time in relation to the weather and the fact that I'm traveling and I am perhaps less confident that I can fit in my physical activity because I'm not at home. So those are sort of relational algorithms that could decide what type of message or whether to message me about physical activity. And then the delivery method, we're going to talk a little bit about that today across the talks, in that we think a lot about tailored text messaging. We can also tailor push notifications for app, or push a notification and have in-app messaging. So all of these are different delivery messages, have the message in the app itself. You can have tailored feedback messages, tailored emails that go out. So there's lots of different ways we can deliver our intervention content. Okay, so what do we know about tailoring? So from good old-fashioned print, we learned that these early generation tailored interventions were delivered via print. So the computer algorithm would have, the very first tailored intervention I worked on was with Bess Marcus back at Brown, and she had answers to survey questions about physical activity that went through like a Scantron, and then we had the baseline variable data, and then we would put in these very specific responses, and you would get a tailored print feedback that would get mailed through snail mail. So there have been a lot of studies on tailored print interventions, and generally more tailoring seems better, and the effect sizes are bigger when more of the variables are tailored. But really there's a tension between how much tailoring, and I think especially as we move into big data, and those of us who have been working in this area know that we can tailor on many variables and in relation to others, but it does add to the expense, and it adds to the potential that you get it wrong. So if you tailor incorrectly, are you going to destroy the trust that the person has in the messaging that you're getting? Are they going to perceive this as less relevant, less relatable, et cetera? So we have to decide which items are the most important to tailor on from a cost effectiveness perspective. So we think about certain categories of variables that we might want to personalize or tailor on. Those that are considered personalization variables, like using someone's name, remembering key dates, so thinking about prompting past successes or other things that are actually more behavior change techniques, but pull in some of these ideas. Raising expectations, or what we often call priming. So some data has shown that if you just tell folks and make sure they know that this is tailored and personalized to them based on their information, they'll actually read it. They'll pay more attention to it in terms of time on page and other data like that. And then matching information based on their background characteristics. Feedback that you might deliver can also be tailored across a variety of dimensions, so descriptive, telling people what they did. And I think we know across a lot of areas of prevention science that when we provide feedback about variables that folks may not, are not obvious, so we're giving them information that is not obvious to them. So I know how many days I was active this week, but it might not be obvious to me that I've hit a record with my activity in terms of consistency over the past 4 weeks. So those might be things that are not as obvious to me as just knowing my frequency. And then you could have evaluative or comparative feedback. So we've been experimenting a bit with behavior change techniques like social comparison, and so comparing to others. And these are contentious types of behavior change techniques. Not everybody loves them, and so this is an important variable to consider. And then content matching, so looking at their status, so if I have certain outcome expectations, or if I have certain levels of my beliefs or attitudes, you might want to tailor on those variables. And then we have dynamic versus static. So the early days, people would assess early and then tailor and provide messaging over time. And so if you knew something about me at baseline, you could give me messages that were considered tailored over time, versus dynamic tailoring, where you're constantly assessing my values on these different variables, and whether you're assessing all the variables or where I am over time, and then retailoring and delivering messages that are personalized based on change or based on my new status on those variables. That is considered dynamic tailoring. And we're at a point now with receiving passive data and other things where that can be tailored multiple times per day. And so my status on these variables can change hour to hour. And so how often, how dynamic should we be making these kinds of interventions? So what we know is that multiple contacts, and this is across multiple studies and meta-analyses and others, is that multiple contacts generally work better. What we don't have is an upper end. So we've been doing some research lately where the average number of contacts was 2 times a day. Is that too much? Or 10 times a week? So in the early days, it was like 3 messages a week maybe, or 1 message a week. And so we're sort of wondering, and those are some of the research questions that need to be tested. We know that including theoretical, demographic, and behavioral constructs in a dynamic tailoring fashion seems to work better, and that using 3 or more constructs seems to promote better outcomes. So these are things for us to build on, right, with the new data and leveraging continuous data streams that we have. So that brings me to how we're going to get the data for tailoring in our interventions, and we can follow a more active data collection where we ask the participant to track their behaviors and be involved. And this promotes self-monitoring and awareness, but it also has the con of potentially providing more burden. And if a participant doesn't engage with this type of data collection, we don't have the information to tailor on. So now we don't know what their status is, and so it's harder for us. And the level of burden can vary depending on what we're measuring. So very intermittent behaviors are less burdensome than ongoing or daily or other behaviors. So you want to think about how much burden and how often are you expecting these variables to change. So it may be that some variables are more impervious to change, or you might only need to assess them every few months versus variables that you're assessing every day. So these are some basic examples of how burdensome it might get to answer questions as an active participant in the data collection. So, answering in a text message which emotion resembles how you're currently feeling, 1 to 6, versus having people fill in a color block about various behaviors that they're doing over time, versus getting very detailed about how many calories someone might consume. So depending on the behavior, depending on the area, having active data collection can be more or less burdensome to drive the tailored messages. Now today we have more passive data collection opportunities, but it also means we have more data to manage and more data to consider in the algorithms that we're developing. So we can use common smartphone features, and I know others are going to talk about this, and we've been doing this in our work, but geofencing to identify where someone is. So for example, knowing that I'm here at this conference, the algorithm would consider differences in whether I've been active yet today, whether I weighed myself on my smart scale, expecting me to necessarily have brought my scale or tracker with me. There might be different things that we would consider based on where I am. Also, messaging based on location and knowing whether someone is near a retailer or an establishment or a place that is risky for them, then many times we can offer up messages that are based on that location as well as their status on the behaviors. We can use accelerometry in the phone, so not relying on a smartwatch, but knowing that they're not as accurate, we need to adjust the algorithms if person A's data is coming from the smartphone and person B's data is coming from a Fitbit. So we have to change what the expectations are based on where the data is coming from, et cetera. And then there's a real tension here about whether burden is always bad. And I think if we think about this from a theoretical perspective, building awareness is often sometimes part of what we do, and that's why we're asking people to monitor. We're asking them to pay attention and have a level of consciousness about what their behavior is. And so this study shows that Turner McGreevy looked at different ways of doing dietary monitoring, and they actually found that the passive data collection, people were more likely to forget to even do it. So taking this is food photography versus actually regular type of monitoring. So the passive data collection was viewed as not as likely to help them build habits. So we're getting better and better, but we have to kind of think about or study and understand whether that burden is actually helping with other aspects in our behavior change theories. So you can also have subjective versus objective. So are you asking people how they feel about their progress, or are you just inferring it from the objective data? And so we can look at, for example, objective data about weight loss or average weight loss per week, but sometimes the same value, so losing 2 pounds, is perceived as poor progress by participant A and great progress by participant B. And so having more of that data that is more contextual can really help you get your tailoring right. So we're using lots of wearables to detect all of these. In general, depending on how you're developing your programming, the data from the wearable is going to go to the participant's smartphone, and then it's going to go to the cloud, and you're going to have all your algorithms and your tailored messages and your libraries there, and then you're going to be passing messages back to the smartphone through some type of mechanism. And generally, we think about a couple of different ways that these sensing variables are categorized. So again, some of these require active sensing, so scanning a glucose monitor, or now having to accept a weight from your smart scale in order for it to be received on the app and then sent into the cloud. And then opportunistic or passive sensing, so trying to build algorithms to detect certain behaviors. And certainly for many of you in smoking, people have been doing this for a while in terms of trying to look at movement and other things. We're doing a bit of it with eating and trying to actually use some other measures to approximate or as a proxy for the behavior that we're interested in. And then looking at social network data can really also be another helpful contextual variable that's a passive sensor. So what are we going to do with this? What are the options? If we've looked at Descriptions of interventions, this provides very little. You know, we might know that they collected data, but we know very little about what they delivered in that type of tailored intervention. Even if they told us the variables they were tailoring on, there's a lot of black box about what these tailored interventions look like. So I'll give you an example of a couple of the text messaging interventions we've done that have included both tailored and targeted. You can see here that there were 4 messages sent a week. The timing was not tailored. Some of the messages were related to their point in the program, so we would consider that targeted, because if I started with group 1, you know, I'm now in week 5, but someone else in the same calendar week is in week 2, their content of their text message is going to be different. That's a targeting variable, versus things that are more specific to me, that are tailored feedback messages. So in these 4 messages a week, only 1 was tailored. So this is a fairly low level of tailoring. Versus you could have another intervention where you can get even more specific. And for those of you familiar with the BCTs that Susan Mickey has promoted that we use to try to specify and have greater specificity in our intervention, you can have a text messaging intervention. Again, this is bidirectional, so we're asking for information back and then we're texting them again. This is a hypothetical intervention, but what you can see here is, good morning, what is your daily walking goal? Well, that's goal setting behavior. That's 1 BCT. Okay, prompts and cues, don't forget to walk today. If this is coming at another time, they're giving a prompt. Self-monitoring of behavior, the person has texted back how much they did today, perhaps based on a requirement of the program, and then giving them a message back about, you walked 4 miles, you've exceeded your goal, you're a rock star. So that's both feedback on behavior, but it's also social reward. So even in 1 message, you can have multiple BCTs. And we went back to do a very thoughtful analysis of all the text messages we've been sending, and we found that sometimes in a single text message, we might have 4 BCTs. Is that overwhelming? Are we asking them to do too much, giving them too much information in a very short text message? So I think there's a lot more work we can do here. So we're going to talk about different ways of giving messages, and I think for many of us who want to have more objectivity in engagement, so looking at, does our message lead to engagement with the message, we want to have a way of tracking that. And text messages don't give us a very accurate measure, and in-app notifications do. But what we found is that there's several cons to these. They can be missed. There's concerns about privacy. In the notification, it's an extra step because we don't want to give the whole message. So here you can see in this notification, hello, check out our new message. You don't actually get a message. You have to now click on this and go over to the behavior page in order to get the actual message. So we're adding more steps. And that's a trade-off in our objectivity versus actually something that's more perhaps convenient or easy for participants. And so what does the next generation look like? I'm going to spend just a couple minutes here talking about what I think we need to do to make these the most effective and actually optimize their effectiveness. So I talked a little bit about more context and having more context to those messages. And I think if we look across the automated messaging, what distinguishes those from human delivered interventions is that they take the objective data and don't have much about the context. And when a person is sitting with us or we're having a conversation, we're gathering all kinds of context cues. So this is sort of our next challenge. And then the other is that the dynamic tailoring has been change on a specific variable, but not very pattern inclusive. So looking at someone's patterns over time and understanding whether the same change from this week to last week for me versus another person actually means something very different because I've been on an upward or a downward trajectory or some of that. So including that pattern type of messaging is going to be our next frontier. And then tailoring what we ask people to do. So we tailor the goals, but also having more hyper-tailoring of the content, maybe based on those BCTs, what seems to be working, what they're engaging with, and then our tools. So having more interactivity in what we're delivering as opposed to passive pushing, expecting people to read these messages, I think will improve our intervention success. So how do we get context? Well, context data, we can sense it and we can develop algorithms to to try to understand what that context might look like. So knowing where I am, knowing that I'm here, knowing that there's tons of Bluetooth signals around me. If I was thinking about whether to deliver a very personal message right now, this context would not likely be a time for receptivity. But there's also kind of old-fashioned or fairly low-tech ways, which is to ask people how they feel about their progress. So we're taking away some of the burden by having them monitor everything, but we're still asking them how they feel about how they're doing. So they're still reflecting, they're still having some type of analysis that they are doing, and that can help us understand the person who has the same objective data but feels poor about it versus someone who feels pretty good about it. So traditional e-health interventions are typically delivered on a fixed schedule, maybe a lesson's delivered on Monday, a text message on Wednesday, another text message on Friday, and then maybe a feedback message that's delivered in the app on the weekend. So multiple contacts, but pretty predictable, versus newer interventions which are adapting every day, multiple times per day. And I apologize that there's some challenges with the formatting going from my Mac to this view. We thought we caught them all, but you can see that there's some. So the tailoring variables are important. We've talked about that. The intervention options, what are we delivering based on those? And then the decision point. So when are we analyzing? When are we deciding to look at how someone's doing? And then when are we deciding to deliver those messages? So all of those pieces of data need to be considered in terms of helping us decide how much to adapt. And I think that's the next step. Is we know that in general, more tailoring has been better, but we don't have the upper limit. We don't know how much, and we don't know how often. So these are some questions that I think can be answered with some of the optimization designs that we're going to talk about later today. So the other, real tension in the field is how much tailoring versus how much targeting. Targeting is cheaper. Targeting is easier to get right in a way. Because it's a much higher level of splitting, so we're either lumping, or it's actually a higher level of lumping, it's less splitting, but sometimes people don't really identify with the group that we've decided to lump them with, and so there can be risks to both targeting and tailoring, but in general, targeting is considered to be more cost-effective, although our newest data collection techniques and other things make tailoring more possible at the population level. So we're always going to be thinking about this, even in levels of tailoring. So if we assume that tailoring is good, how much tailoring? Because every time we are building these complex algorithms for these types of mobile interventions, it's costly. And it's costly for us to do the testing, to do the quality control, to make sure the variable streams are coming in, to make sure the algorithms are working right. And there's a whole level of variables and a whole field that's called about tailoring wastage, which we don't have time to talk about today, but there are going to be some levels of variables that your population is never going to experience, but you have to have messages in your library for that possibility, because if you don't and someone does, then your system will, provide nothing to that person, and it'll be not helpful for them. So we have a lab at UNC that's focused on optimizing health through precision public health interventions, and a lot of collaborators, a great group of professors that work together across a variety of these interventions, figuring out how adaptive is, how much adaptation should we be doing. So we have a couple trials going on right now. One is an optimization trial that is trying to understand how to develop a just-in-time adaptive intervention. So we're testing a core weight loss intervention that's in the mobile app that we've been building on over time, but we're testing various components to try to understand how much more adaptation. So this is not a traditional optimization design that you might see where some components are off and some components are on, and you're trying to decide whether to include the component or not. This is an optimization trial where we're looking at the level of the component. So we have a factorial design here where we're looking at the diet monitoring approach, how adaptive the physical activities goals should be. So are they adapting every day, or are they adapting once a week? So that's a decision point to adapt the goal based on the data we get every single day and change it to adapt the content or the prescription versus adapting it once a week. And then we have decision points. So our decision points decided, and they're throughout the day, and they're based on what the person told us at baseline, or are we constantly collecting data to decide when we should be assessing? I'll give you an example. So if I'm always an evening exerciser, the adaptive rules would learn not to look for my activity in the morning because it knows that I'm constantly exercising after work. So it's not going to be using that decision point, it's going to be using a more personalized decision point for me. And then the decision rules. So how complex, and this is really taking today's behavior versus taking today's behavior with some of that pattern over time. So thinking about how complex are those rules, how many variables are we considering in relation to each other? So that's another piece of the adaptive versus the standard. And then giving people choice. So we have messages, and based on their liking or disliking, the probability that they'll get those messages again changes. So that the message curation is much more adapting to their behavior. And so we have a conceptual model here. In each of these intervention components, we're targeting one theoretical mediator to try to enhance the JEDI. And then our behavioral mediators are weighing behavior, diet behavior, physical activity behavior, and ultimately weight loss. It's a 32 factorial, and we just have published the design paper this year. So if you're interested in more information about that, Brooke Nizami is the first author on the factorial design paper. And then we have another trial that Carmina Valley in our group is leading, and this is looking at trying to optimize what we deliver. So this is a micro-randomized trial where at different points during the day, a person is randomized to get a certain message type or not, so that we can look at the effect of that message on their behavior. And so studying 7 different BCTs to evaluate their effectiveness on the different behaviors, because there might be certain techniques that are better for diet behavior versus physical activity behavior, et cetera. So getting more specific about the content of what we're putting in our text messages. So my suggestions in conclusion are that advanced tailoring that mimics what behavioral treatment providers would do is going to work the best, and that it's not only the values of the variables, but which variables and the algorithms probably need to change over time. So our expectations for what those algorithms might look like at the beginning of a program versus later in a program probably should change. And in order to make the messaging more interesting and more relevant, because again, personal relevance, tailoring works because of the attention people pay to the message and the relevance that they perceive to their life, is probably based on more variability of the format and the variables that you focus on, so not focusing on the same things all the time, with a high degree of branching logic to be successful. We're doing some experimentation with the algorithms can also be driven by machine learning. So Nisha Gottfriedson and Brooke Nizami are leading a study to see if our clinical algorithm, so what we think is our clinical judgment, is actually improved by using more of a reinforcement learning model to select the behavior and to work on the algorithm. So lots to be done there. And we can take advantage of sensor technologies to collect the data and then, really change our intensity of intervention based on response patterns. So we may know that someone could benefit from more messaging at a certain time, and we can back off and give them more space and not message them at other times. And that's sort of looking for opportunities to build in silence and times when people may need a break from these interventions. So thank you. I work at the Nutrition Research Institute, and our motto is Eat Uniquely, because we do a lot of work on precision nutrition, but my work is in prevention and behavioral science, so I think it should be Treat Uniquely, because with tailoring, we can really try to get at what the individual needs and do a much better job with our treatment. So thank you.
Thank you so much for that. That was fascinating, and I learned so much. Our next speaker is Dr. Patrick Carter. He's a professor of emergency medicine at the University of Michigan. He's the co-director of the University of Michigan Institute for Firearm Injury Prevention and the co-director of the University of Michigan Injury Prevention Center. I'd like to say that he's been doing firearm injury prevention since before it was cool, and I'm excited to be hearing from him related to firearm injury prevention and the development, testing, and implementation of emergency department-based interventions. He's had funding as a PI or co-I on grants from NIDA, NIAAA, CDCP, and NICHD, all focused on injury prevention. So let's welcome Dr. Carter.
Thank you so much. And I'm going to talk a little bit about using our sort of journey with digital technology in the realm of tailored violence prevention and what sort of is universal to the things that Deb brought up, but also maybe what some of the nuances and unique aspects are for the population that I specifically do interventions with. Let's see if this works here. So I do want to acknowledge that the work I'll be presenting is the work of our group and our team and a lot of collaborators and our funding disclosures for the work that I'll be presenting. So I think, as most people are probably aware, violence is a significant public health problem, firearm violence in particular, the most sort of severe aspect of violence involvement, surpassed motor vehicle crashes as a leading cause of death, especially for youth and young adult populations in 2017. And so 60% of those firearm deaths are related to interpersonal violence. And it really is a spectrum of disease from lower level fighting to violent injuries, to firearm violence, to increased occurrence of injuries and mortality. And there are a predictable set of risk and protective factors that we can intervene on to adjust those trajectories. And the work that I do really focuses on how do we use an emergency department visit as an opportunity to intervene with folks who are at risk for these negative violence trajectories. And we know that before somebody comes into the emergency department for a violent injury, there are about 50% to 60% of that population comes into the emergency department for some other reason in the year before. And so how do we use that to reach this population that is often not in school, may not yet be engaged in the criminal justice system, but is at risk and is engaged in risky behaviors? And this work really started with the Safer Teens intervention, which is a brief 30-minute behavioral intervention delivered by a therapist in an emergency department setting that combines a combination of motivational interviewing, cognitive behavioral skills training to address violence and associated behaviors around substance use, and showed really in that single session intervention, just delivered in an emergency department during any visit, there for sore throat, ankle sprain, abdominal pain, or a violent injury, that we could reduce violence outcomes for out to a year, including aggression, dating violence, and then associated substance use and mental health symptoms. And as our group thought about how do we take this intervention that was delivered in a really tightly controlled randomized control trial and translate it into the clinical setting for use, you know, we know that as we translate these types of behavioral interventions into clinical practice, that they lose some efficacy. And so we wanted to think about ways of boosting that efficacy, that adding that second ice cream scoop to the cone to increase the dose that the individual is getting, and began to think about the role of digital interventions in helping to add to that single emergency department encounter. And just about the same time, we saw this explosion of new technologies that were being used in interventions, a lot of which you heard about earlier, nutrition, you know, telehealth interventions, text message, and apps and wearables. And so the question is, you know, as we start to think about how we design and develop and do these interventions with a traditionally hard to reach population that's at elevated risk, what are the considerations that we need to think about specifically for this population? And I'll say some of the ones that came up, and I think will come up in the ethics discussion on Friday, really around what are the privacy considerations for text messaging, for apps, for delivery of digital messaging where somebody might be engaged in partner violence. They might be a victim of partner violence and they don't want their partner to see the messaging on the phone, or they're engaged in illegal behaviors that if the police confiscated their phone, you don't want them to see any of the messaging that's specifically geared around some of these illegal behaviors. What's the role of individual versus group interventions? So for example, a lot of the social media interventions involve folks commenting or intervening or making messaging in groups. Well, when you're dealing with a group that's violence involved, their involvement or engagement in violent behaviors as they intersect with other folks in their population may lead to retaliatory behaviors that have to be considered. Also, a lot of the structural barriers that we know exist in communities with elevated rates of violence extend to structural barriers in technology. So while they may have phones, the technology on the phones that they're carrying in their pockets may be 5 years old. And so how do you design or develop an app or a messaging program that fits with the technology that exists in their pocket? Also, these communities may not have the latest cell towers to support the technology of a more advanced intervention. So how do you ensure that you're designing the right technology for the population that you're intervening with? So as we sort of entered into this foray of what do we do to enhance the efficacy of a violence intervention, you know, our first stop on this journey that I'll tell you about was to think about translating the Safer Teens intervention to a web-based program that could collect baseline information that was during this brief intervention delivered in the emergency department, and then deliver tailored text messages after the emergency department. And this was sort of a simple SMS tailored intervention, so it involved both assessing behavior, in this case the self-efficacy question, and providing a tailored response, but then also delivering tailored messaging after that that was based on their baseline session data that was collected, either messages around their goals, the benefits of avoiding fighting, tools, or strengths. And as Deb talked about a little bit earlier, this was designed as a two-way text messaging intervention, so they could also pull messages around tips for coping, tips for avoiding fighting that they found that they might find useful. And so this, you can see an example on the right of some of the messaging that was delivered as part of this program. So the delivery of Safer Teens from a remote telehealth therapist basically achieved similar outcomes to the original randomized control trial. But what I want to focus on a little bit here is the responsive use to the text messaging. So, you know, over 80% found that text messages were useful, they were low burden, easy to understand. But we did note that there was low utilization of pull messaging. And you can see on the right bottom a quote from somebody who entered into the program that really speaks to, I think, the value of the tailoring and the personalization that you heard about from Deb, which is that the fact that the texts that were sent to me were directed towards me and only me and my goals, it made me feel heard. And especially in a population that doesn't have access to counseling, it doesn't have access to a lot of resources and services, making sure that they feel heard and that the message are personalized and tailored in that way, I think is especially beneficial to responding to the intervention. One of the unique aspects of we sort of anecdotally discovered is that while we told youth in the program that, you know, these message systems were not monitored, they wrote messages for themselves and they wrote them back to the program. And they told us in interviews afterwards that they did that to store the messages and remind themselves of them. And I'll get back to why that's important later. So now as we sort of continue along on our journey, thinking, okay, so we have developed this brief intervention with an associated text messaging program, you know, are there opportunities for an even increased dose of intervention content after an emergency department visit? And can we then think about how we optimize the intervention delivery to right-size the dose for the right-sized folks and their engagement in violence and substance use behaviors? And so we sort of moving along further on this journey, focused on the addition of either telehealth remote sessions after the emergency department, focused around developing coping skills, providing social support, pro-social activities, and access to community resources, or a more deeply tailored now SMS program that could really think about how do we tailor to upstream factors around mood and anger and then motives for fighting and substance use and provide the right tools in a tailored fashion. And so the text messaging program here became a much greater library, much more personalized, much more tailored, really focused around a range of behaviors, delivered 2 messages a day, one in the morning, one in the afternoon. And as you can see on Thursdays, they received a self-written message. So this is based off of the feedback we got from the prior study, which is asking youth to provide a message they would want to hear about their strengths and their positive qualities. And you can see an example of some of the messages that youth in this study wrote to themselves. And then also providing these more tailored messages that are based on weekly surveys instead of just tailoring on baseline data, also doing these assessments at a weekly basis and being able to tailor more specifically around what's going on. And again, this is sort of midway in our journey on this pathway that Deb talked about in terms of tailoring. So tested this in a SMART trial, basically trying to assess as a first stage, what's the comparison between text messaging and health coach, these remote health coach calls after the emergency department, and then also testing as a further stage what happens in terms of response and non-response and whether we could ramp up or ramp down the level of intervention delivery after the emergency department. I'm going to focus mainly on the stage 1 findings because it's relevant to the talk here, and stage 2 is also somewhat underpowered due to COVID and recruitment challenges. But what we saw overall for the sample is that it's similar outcomes to the original Safer Teens trial in terms of reductions in both aggression and victimization behaviors as well as alcohol and other drug use. But what's interesting is in the head-to-head comparison between the sort of more finely grained tailored text messaging program with these 2 text messages delivered daily versus these health coach calls, which we assumed would be more intensive and would have a greater effect, we actually didn't see a difference in outcomes. And I think a lot of this owes to the fact that the engagement with these health coach calls, which required somebody to actively schedule an appointment, have the phone call, have the discussion, access the resources versus this more passive delivery of a text messaging program that was low burden, that required them to just do the weekly survey where we saw much higher rates of engagement, really probably explains that finding. So, okay, so moving further along in our sort of journey here, and thinking about the programs that I've talked about so far, really focused on lower level fighting behaviors, youth who were in the emergency department, who had a history of some fights in the past couple of months, who may be engaged in some lower level substance use. How do we take this type of intervention and really start to think about it for a population that's engaged in risky firearm behaviors, that's we know has much higher severity substance use, has much higher severity violence involvement, maybe doing things like carrying firearms while they're intoxicated or high, maybe engaged in using firearms to threaten people, to retaliate for prior behaviors. How do we think about delivering an intervention for this population that builds off of what we've already learned? And in this case, we went with the idea of a blended intervention where we're both increasing the dose with these telehealth sessions after the emergency department, but also giving them more in terms of our digital intervention and designing the digital intervention to support those telehealth sessions. And so in this case, we developed a smartphone app, and that's called Project Interact, or the project is Project Interact, the app is Interact. So again, thinking about how we develop and intensify this type of intervention, combined both the elements from the original trials around Safer Teens with motivational interviewing and cognitive and behavioral strategies with a more intensive focus on providing care management also after this emergency department visit. We know this population of youth faces a lot of structural barriers in accessing services and resources in their community, and how do we enhance that and help them navigate some of those barriers after the emergency department? We know that this digital intervention, these health coach sessions are likely not enough to affect these behaviors long term, and that this is really an opportunity to engage them and move them into the services that they will need longer term. Oh, one thing. So the intervention was designed as a 3-session behavioral intervention delivered either in the ED or over the phone by a therapist, and then paired with the smartphone app. And the app has a number of features on it, which I'll walk through here in a minute, and a number of the ones that Deb sort of alluded to earlier in terms of both the intervention elements, but also some of the additional considerations around privacy and ways to think about engaging youth in actively going into the app and responding to the content that's delivered. And I will note that one of the things that was brought up is this idea of these push notifications and having to actively go into the app, and certainly in terms of an ethical consideration around what gets displayed on an app. notification versus the more deeply tailored messaging that you can deliver in-app in comparison to our text messages. So one of the advantages of an app is we can collect survey data that's much more deep in terms of both their engagement and risk behaviors, their mood states, as well as motivations for different behaviors. And we can also collect, in terms of onboarding, pictorial representations of things that they identify as their strengths and goals, and then are able to tailor that and feed that back to them as part of the messaging. And so I think some of the advantages of an app-based system are this ability to provide content that's more engaging. So in terms of tailoring, this sort of moving into that next level of tailoring that we talked about, we were assessing behaviors, mood states, other factors on a daily level with EMA, but we're able to do the tailoring in a much more complex way where we can assess trends in behavior over time, and the algorithm can assess whether or not their anger over the week has been increasing or decreasing, whether their anger in the past few days is much higher than it has been in prior days compared to prior weeks, and really use that to help tailor the messaging to be more specific and personalized and tailored to their behaviors. Also, we can tailor on multiple factors, as you heard Deb talk about earlier. So not just whether or not they carried a firearm over the prior week, but what was their motive for carrying the firearm, and whether that was motivated by a fight or altercation, and that they're worried about retaliatory violence. And so we can use those things to help fine-grain the tailoring and provide more detailed messaging around these behaviors. So you can see here an example on the left of some of the messaging that gets provided in the app, and they get one motivational interviewing tailored message per day and one cognitive behavioral therapy skill or strategy. In addition to that, we're able to link those to infographics or psychoeducational materials that are more targeted to the population, but may not be as tailored to the specific behavior that they're engaged in. And then also link to resources and other elements of the app to direct them around in the app to additional services. So I just mentioned, the ability of the app opens up a whole new world of things that can be tailored on, not just their EMA responses, but also passive data that's collected. And so you heard Deb talk about that a little bit earlier. I'll give you an example of one way we did that in our app, which is location messaging for what we called with participants trouble spots. So we knew from an ethical standpoint, we did not want to ask specifically about why a location might be a risky location for them. We asked them in the emergency department to identify places that they felt were high risk for them. They either felt they needed to carry a gun when they were there, they felt like this was the place where they had used substances or gotten into altercations in the past, and they were concerned that this location would be high risk if they went into in the future. We asked them to not name it with why it was risky, but to just give it a generic name that would be relevant to them. And then we were able to provide them with just-in-time messaging as they entered into those locations and direct them to pro-social resources that they had previously identified within the onboarding of the app. And then building on the work that we had done earlier in messaging that the youth provided themselves, are able to collect messaging that can be provided back to them. And then to enhance novelty, rotating that with other types of messaging, such as messaging they might provide to others, and really honing in on a altruistic sense that people had to help others in their community. We were also able to build in testimonials that we've collected from youth over the years that provide both psychoeducational and behavioral strategies for addressing violence and other tools. This is one example of one focused around anger management skills. And then on-demand resources. So as opposed to having to pull now, people could go into the app and look at some of these on-demand resources, either a one-touch pro-social contact that they have identified as somebody they would reach out to when they were feeling stressed or in trouble. Crisis line services. We know a lot of these youth have elevated rates of depression, anxiety, mental health issues and concerns, and so being able to access and contact crisis lines in the moment when feel that they're at risk, as well as access to care management resources from their community. You can see this is tailored by their community that they live in, and also that the therapist would provide as part of the behavioral intervention. So we tested this in 2 emergency departments in Flint. So we enrolled youth who had been carrying a firearm and had a smartphone, and provided both the 3 sessions of behavioral intervention plus the addition of the smartphone app versus a control group where they had assessment only. So this was, they were provided with an app in the control group that assessed behaviors but did not provide any tailored messaging and did provide a resource brochure. So this was done in Flint, Michigan and Saginaw, looking at 3 and 6 month outcomes. And I will say, I won't focus a ton on the sample characteristics except to say that only about 6% of the youth were in the emergency department that day for a violent injury, and less than 10% were already engaged in the criminal justice system. So we are reaching the population that we're hoping to reach before they enter into more serious or significant behaviors. But 3/4 of them are involved in risky firearm behaviors, either carrying a firearm while they're drunk, high, or engaged in other illegal behaviors, discharging a firearm at risky times, such as when they're in a fight or when they're running away from the police or law enforcement, or actually using the firearm in a threatening or aggressive manner. So what we found is we were able to decrease the frequency of risky firearm behaviors at 6 months. Didn't see a difference between the groups at 3 months, but at 6 months saw a significant reduction in risky firearm behaviors over that 6-month time period. Just in terms of other outcomes, decrease in victimization, so their risk of victimization, which likely is a precursor to retaliatory violence, as well as their experiences of violent injuries in that 6-month period. Also, in terms of thinking about mechanisms underlying some of the violence behaviors, saw a decrease in substance use and occurrence of anxiety and depression symptoms at 6 months, and decrease in delinquency and violent offending behaviors that we know are precursors to further engagement in the criminal justice system. So with that, I'll say, digital technology, I think you've heard Deb talk about it, I talked about it, I know Kate's going to talk about it too, is promising for extending the reach and dose of these types of violence interventions that start or initiate in a clinical setting but continue afterwards. We know these interventions address both risk factors as well as bolstering strengths resources, and that tailoring increases, as you heard about already, the relevance of the messaging, especially when it's delivered in close proximity to these risk behaviors. But I think really a key element, especially of the work that I do in these types of interventions, is really understanding the community and partnering with the community members, both to inform the messaging. All of the messaging that we have done is written by youth, iterated and then rewritten by youth before it's ever entered into the tailoring algorithm, but also to understand those contextual and end user issues that really inform the modality that you're choosing. It wouldn't be appropriate to start with a smartphone intervention in a community that only has 3G Wi-Fi access, and to think about how those constraints may inform the type of digital interventions that you do. And then I think just in terms of future directions, you heard a little bit about this tension between low burden text messaging type interventions and higher intensity, higher burden app type interventions that can provide a depth of tailoring and content that can't be provided in these sort of lower burden, but which is better. And thinking about how we look at and determine the key ingredients of these interventions. The 3-session behavioral intervention I talked about, paired with the smartphone app, is resource intensive. It required both a lot to develop it and to maintain the technology, and also requires the therapist to deliver those components. Which are the key ingredients? And that's sort of a next stage for these types of interventions, which can obviously be sorted out in optimization trials, which I know Kate is going to talk about. So I will turn it over to her to talk a little bit about that.
Thank you so much. I'll let you get up there, Kate. I hope, yeah, this is working. So Dr. Kate Guastafaro is an intervention scientist by training. Her work's devoted to the development, optimization, and implementation and evaluation of effective, efficient, affordable, and scalable interventions with high public health impact. She's an expert in most strategy. So great setup, Pat, thank you. And her expertise is in parent-focused, multi-component behavioral interventions to prevent child maltreatment. And we are excited to hear from her.
Awesome. Well, good morning. Oh, thanks. Thank you for the invitation, and I do feel very queued up. I took a lot of notes. Who knows? I'm going to organize new thoughts as we talk. So fun for us all. So I'm gonna start us kind of at the point of developing optimized interventions and using that data to then scale it and make population level impact. So this is a little bit more theoretical, but inspirational, all right? That's my goal. So what is an optimized intervention? You've heard Dr. Tate, Dr. Carter talk to us about their work in developing an intervention that works best for people in different circumstances. So they didn't say this necessarily, but they're creating optimized interventions. And an optimized intervention is an empirically derived intervention that includes components that produce a desirable outcome on our desirable impact on our outcome of interest at a meaningful magnitude, whatever that might be, but also, I think I have an and, that strategically balances that outcome with constraints that are imposed by the need for that intervention's affordability, scalability, and efficiency. Look, there it is. So how does one empirically identify an optimized intervention? Well, according to us, you do this empirically and systematically. And the different frameworks that lead us to that goal, I call translational frameworks for intervention development. So there are a couple that kind of fall into this definition. And in this paper, my colleague, Dr. Angela Famatter, and I kind of map these different frameworks onto each other and the NIH stage model. So you might be familiar with the MRC or the orbit model. I am focusing on most, but I do want to say that there are these different frameworks and strategies towards creating interventions, and I obviously am team most, but I'm actually team use a framework and just be strategic about what we're doing. Alrighty, so most, or the multi-phase optimization strategy, is one approach to intervention optimization. And 2025 is the 20th anniversary of most, so it is still innovative, but it has a good foundation and roots for us to learn from and to keep iterating. It is comprised of 3 different phases. I'm not going to go through them, but this is that systematic approach to ultimately arriving at an optimized intervention. So, most is the approach. The paradigm that we are talking about is called intervention optimization. And so intervention optimization is the process of achieving that strategic balance between an intervention's effectiveness and these other implementation constraints. So it's cost, its scalability, and its efficiency. And just want to call out that, like, if you were interested in ever citing or talking or publishing about intervention optimization, and most, this paper, which came out in 2024, is the one to use, not one that came 20 years ago. This is the paper that has all of the current thinking. All right, so this is our paradigm, in a process here of creating this strategic balance. So intervention optimization takes inputs from lots of different fields to arrive at the manner in which we are engaging in this process. So we've got behavioral science, industrial engineering, health economics, decision science, and implementation science that all come together and contribute to this process and way of thinking called intervention optimization. I guess I was really into transitions yesterday, sorry. So again, this is the schematic of most, and the bulk of this talk is focusing on the optimization phase. You heard about the development of the components and how we've thought about the selection of different strategies to include. Those are things we're familiar with, right? That happens in the preparation phase of most. I'm focusing on the experimentation of those different components and what we can do with those data. Hold on, I think I'm gonna say this again, but it's worth repeating. There are any number of experimental designs that can be used in intervention optimization. You've heard about a SMART, you've heard about an MRT, you've heard about a factorial experiment. These are all appropriate, and it really comes down to your research question. So here's my TED Talk moment. MOST is not a method. It is not an like off-the-shelf, plug-and-play kind of method. This is a strategy to intervention optimization, and the experimental designs are those factorial experiment, SMART, and MRT. MOST is not an experimental design. There you go. That's my reviewer 2 comments to you now. Alrighty. So in this journey, we are just going to say we are at the point of conducting our optimization trial, and we've done it. We've created our data. Here we are. So this the data come from a optimization randomized controlled trial, an ORCT, an optimization trial. They all mean the same things. The purpose here is to assess the individual and combined performance of candidate intervention components. They are candidate because they may or may not make it into the optimized intervention, but that's what we're trying to find out. And the designs that we use for this ORCT are all from the factorial family of experiments. So you've heard about the factorial experiment, fractional factorial, the SMART, the MRT. We didn't get into hybrid experimental designs, which have been kind of iterated on by Billy Nahumshani. And these should not be confused with hybrid effectiveness implementation designs. So I know. But the hybrid experimental designs are where we have interventions that work at different time scales. So maybe there's an aspect of a mobile health intervention that's going to adapt very, very quickly based on where I am, right? But then there's other parts that are more kind of steady state and are not going to adapt on that frequency. So that could be something that we optimize using a hybrid experimental design. All right, bear with me. I promise I'm not going technical. So suppose, I'm going to kind of keep us at the most basic level of an optimization randomized controlled trial. So this is a hypothetical 2 to the 4th factorial experiment. There are 4 factors that I'm experimentally manipulating. Each has 2 levels. This yields 16 experimental conditions. Did anybody just go, oh God? Maybe. Yeah, but that's okay. These different combinations, if you will, of the different components represent different versions of an intervention ultimately. So from the factorial experiment, we are able to estimate the main effect of each factor and all possible interactions. So the factorial experiment gives us so much more information and can answer so many more questions than the typical 2-arm RCT that we know and love. But this gives us information and opportunities to advance science about the individual contribution of each one of these factors and how they work together. Cool. All right, so this was, hold on, go back. This is the design. Flash forward, here are some results. These actually come from an optimization trial published in Translational Behavioral Medicine, led by Sophie Green. And this is just a visual depiction of all of those main effects and interactions, right? So on the y-axis here, we are showing the regression coefficients from the factorial optimization trial. It's just regression, okay? Not rocket science. And don't ask me questions about these data, but the paper's there for you. So we have the outcomes, and then from those outcomes for the main effects and interactions, I'm able to produce a y-hat, or the expected outcome for each one of those different 16 experimental conditions, right? So there's 2 things happening here, right? I'm estimating the main effect for each one of the factors. Cool, advancing science, looking at how they interact. But now, third cool thing, I am putting them together to represent the expected outcome for each one of these different versions of the intervention. Note, we are using effect coding. So that's -1 and 1 in contrast to dummy coding where it's 0 and 1. This is a common challenge when I work with somebody if they're analyzing factorial data with a dummy code. The results are different. So effect coding is how we analyze factorial data. You use the y-hats and kind of iterate back and forth with the main effect and interaction data that you had to figure out which versions of the intervention are most compelling to you, right? Like which combination produces an expected outcome that is meaningful to you and could potentially work within the constraints you have available. So we've done our ANOVA, we've got our data, and now we're going to balance that effectiveness with constraints. And so the method, the approach to do this is called DAVE. We call it DAVE the method, not Dave the person. And this is led by my colleague Jillian Strayhorn. DAVE is decision analysis for intervention value efficiency. It brings in multiple criterion decision analysis and Bayesian principles. We can talk more about those things, but broad strokes, DAVE produces visuals for us to interpret and to make decisions from. So it gives you the different performance of those different intervention options, those versions that I showed you before, and graphs them. So that on the x-axis, I've got its effectiveness, and on the y-axis, I've got its constraints. So constraints, we're talking about its cost, its burden of the participant, burden to implement, whatever that might be and is meaningful in your context. So here is an example. These are smoking cessation data that Jillian is in the process of publishing, but here you go. So you're familiar here, these are our regression coefficients on the left side. And now the DAVE plot on the right has all possible combinations represented for each dot, right? All these different intervention versions. And she's able to identify which versions of the intervention fall upon what is called the frontier of efficiency, which, like, don't you just want to write that in a paper, right? But this helps us narrow it down. So we're not necessarily looking at all 32 condition or different versions of the interventions, but which actually do this balance between effectiveness and the outcome, the constraint. So in this case, they're interested in cost per person. And what you can tell from this graph is the expected cessation probability for the version that includes all components. There's 6 components in this example. Doesn't fall on this version, this frontier of efficiency, but the versions that do have 4 of the factors, components turned on, 2 and 1. So this is an interesting way for us to think about what we are identifying as our optimized intervention. Okay, it gets cooler, hang on, because this gives me on the implementation cost side here an opportunity to look at costs in different places. So if I am in a context, this is my implementation scientist coming out, watch out. If I'm in a context where I do have $400 per person to spend, great. It's very clear. I can pick the version that includes A, B, C, and D, right? But if I have less money and can't afford $400, instead of ad hoc just taking things out that I think will be expensive or whatever, this guides my decision making to say, oh, well, I have $450. I can do BD and it's still efficient, it is still effective. Cool, right? Okay. Thanks, thank you for that. So this is how I suggest it's possible to take an optimized intervention to scale. By using data from an optimized intervention, we're able to think about how this goes in different contexts. So here is a hypothetical example. This is in my space, so child maltreatment prevention, where provider burden and provider time is my greatest constraint. And so I've come up with this hypothetical here where I'm looking at the different numbers of sessions that a provider needs to give to a family and the hours it would take them to do that, okay? This is all hypothetical. And I run this study and I produce this Dave output, right? Do my regressions first, now I've got the expected outcomes, I'm plotting them, and I'm able to look at the effectiveness versus time and make decisions. So, cool. What happens if I have on my staff, somebody leaves and I have more cases that one provider needs to deliver? I'm able to look at this and make a decision on what different combinations of the components they can provide that's still effective, but works within the constraint that I have of only having one provider who now has to go from serving 20 families to 40, right? So this is a way for us to take data from an optimization trial and inform the implementation and dissemination of it in the real world. Okay, so lightning talk here. If you are interested in learning more, we have a website called interventionoptimization.org. It is the landing page that represents our two sister centers that work together. So the D3 Center is at the University of Michigan, led by Billy Nahumshani. And CADIO, the Center for Advancement and Dissemination of Intervention Optimization, is at NYU, which I co-direct with Linda. And the kind of exciting splash I will leave you with is that in May 2026, we are holding the first conference on intervention optimization. And if you go to our website, you can sign up for an announcement of that. Okay, the end. Thank you.
Thank you all so much. That was a great lineup. I loved hearing from all of you. Can we give a round of applause for our speakers again? That was amazing. So we have about 3 minutes left, which I think could be time for one burning question. But please note, we are coming back at 10, and we can ask all the burning questions. But are there any questions right now? Please feel free to come to the mic if you would like to. Okay, so go ahead, grab some coffee and come back, and we're excited to have an active and engaged conversation. Thank you all again. Also, as you're leaving, please pull up your camera on your phone. For any ethics issues that you have, please go ahead and grab that QR code. Do you all mind going back to the ethics slide? Yes, please pull out your phone and grab that QR code and put in your questions.